Hi, my name is Nathan Wong from the University of California, Irvine, and I'm the editor of the Cardiometabolic Clinical Community for CardioSource. And I'm here with Dr. Michael Linkoff from the Cleveland Clinic, who served as the principal investigator of the AleCardio Trial. This presented at the late-breaking clinical trial session. Well, there's certainly been a lot of interest, around the potential cardioprotective effects of dual alpha gamma PPAR activation. And a little while ago, you presented a very interesting trial, the AleCardio Trial. If you could maybe give us a brief overview on what this trial was intended to show, what you did, and kind of what were the results.
Okay, thank you. So the AleCardio trial was designed to test a investigational dual PPAR alpha gamma agonist, Aleglitazar, for reduction of ischemic events in patients at high risk for ischemic complications with type 2 diabetes. So as you recall, PPAR agonists are used clinically. PPAR alpha agonists are the fibrates, which reduce triglycerides and raise HDL. PPAR gammas are the thiazolidine diones that improve insulin sensitivity and reduce glucose levels. So this was designed to combine those beneficial effects and evaluate whether or not there was a positive effect on atherosclerosis. The high-risk patient group were patients who had been recently hospitalized with acute coronary syndrome, myocardial infarction, or unstable angina and had type 2 diabetes. About 10% were newly diagnosed. The rest had a mean 9-year duration of their disease. They were randomized to Aleglitazar once a day versus placebo, superimposed upon what we tried to make excellent standard of care using all the guideline-based and care for their diabetes and their heart disease. And then the intent was to follow them for at least 2.5 years with a plan in an event-driven trial for 950 endpoints. The endpoint was death, myocardial infarction, or stroke, cardiovascular death. And the trial actually was terminated early after a median follow-up of about 2 years, based on a Data Safety Monitoring Board review, which identified higher rates of adverse events such as heart failure, bone fractures, hypoglycemia, actually gastrointestinal bleeding, and reversible changes in renal function, at which point they did a futility analysis with about 55% of the data and identified that there was a less than 1% chance of a successful outcome with regard to superiority. So based upon not wanting to expose patients to risk, even manageable risk if there was no clear benefit, we terminated the trial. We found that there was, for the primary endpoint, there was no difference. There actually were significant reductions with hazard ratios of 0.75 to 0.79 in unplanned revascularizations and hospitalization for unstable angina. But there was an increase in the risk of heart failure and hospitalization for heart failure. There was an increase in weight gain, peripheral edema. As I mentioned before, unexpectedly we had an increased risk of gastrointestinal bleeding. There was no precedent for that. Higher rates of hypoglycemia. The renal effects, as seen in phase 2, were completely reversible. It seems to be a hemodynamic effect. But on the balance, there was no benefit. Now, this is despite having reduced triglycerides by 35%, increasing HDL by 20%, and decreasing hemoglobin A1C by about 0.6%. So another situation where the biomarkers that we rely on to have some evidence of biological activity don't necessarily predict the clinical outcome.
Yeah, well, thank you very much. No, that's a really, I think very well conducted trial you did. I think what's interesting, if you go back to your well publicized pioglitazone meta-analysis, it looked like the curves began to diverge. The curves for events began to diverge between the two groups after about 1 to 2 years, and perhaps we might not, I guess, ever know the answer to that with this trial, huh?
Yeah, I mean, and that's a key issue with particularly metabolic therapies. I mean, certainly in acute coronary syndromes, you often see some benefit in 6 to 12 months, but there are certainly a number of trials of atherosclerosis modifying therapies, lipid trials, CARE, et cetera, where if you didn't go longer than 2 years, you wouldn't have seen the difference. And that's the problem here. Even more so is the problem of should we have been taking patients who were much earlier in the course of their disease, early diabetes, but not necessarily necessarily established vascular disease, is that the situations where you can really interfere with that progression with atherosclerosis modifying drugs. And that's a very hard thing to do because it takes decades, or at least a decade, long periods with large numbers of patients when the risk is that low.
Yeah, I think that's been a major issue with several of these trials, is that they have really taken individuals too late in the disease course, and perhaps we really would have seen benefit. And I was interested to know if you are planning to do perhaps subgroup analysis, perhaps stratified according to maybe duration of diabetes. Also, as we know, results from the Accord lipid trial showed that the high triglyceride, low HDL subgroup did benefit, and perhaps these would be very interesting analysis to conduct.
We had an upper limit of 400 for the triglycerides, so that's difficult. But HDL, actually, that was the only borderline significant heterogeneity with a 0.06 p-value that patients with low HDL seemed to benefit. So that kind of goes along with that hypothesis. And in terms of the new we haven't actually looked at duration, but we did look at the 10% of patients who were newly diagnosed, and there was no difference there. But clearly, over 2 years, the event rates are so low that that's difficult to say.
So I think finally, do you feel if there's any future for actually dual PPAR activation in prevention of atherosclerosis, perhaps in certain subgroups of individuals, based on all the work you've done in this area?
Yeah, this agent is the development program for this agent is discontinued. It will mark the third agent that has been in phase 2 or phase 3 testing, previously Aleglitazar and Aleglitazar. It's not to say it's impossible. I think this theory still works, but these agents are so incredibly complex in terms of which genes they activate, and that it's very unpredictable what their side effect profiles will be in the therapeutic margins. And so I suspect that this is a very difficult and risky class of drugs to develop, and that I don't think it's likely that there'll be other large-scale cardiovascular trials of these types of agents. But we can always be surprised.
Okay, well, thank you very much again for your participation today.